Our next lecturer read medicine at Cambridge and trained at St. Bartholomew's Hospital in London. He has certification in general practice, a higher degree in internal medicine, and a diploma in psychological medicine. He is also registered as a psychotherapist and accredited by the British Association of Sexual and Marital Therapists. As director of the Optimal Health Clinic in Harley Street, London, his caring and considered approach to optimizing health in older age is based on a wide and varied experience. Please welcome to the stage Dr. Mike Perring.
Thierry Hertog talked this morning about the dance of hormones, and it reminded me that perhaps we could think also that sex is like a dance. The good dancer anticipates his partner, has a sense of rhythm, not his rhythm or her rhythm, but the rhythm of the dance. I thought I'll pass that idea on. I like it. I mean quite a lot more perhaps than just in those words by that, because my belief is that we have inherentness in our physiology, in the construction of our nervous system, a way of being sexually that does not require much cognitive function, and may be more to do with listening to our own internal rhythms. And that if we do that well, we will be good at making love, as good when we are older as when we were young. And I think that for older people, whom I mostly deal with, they're 50 and over, many of the things that they're able to have when they're making love are as good in quality as when they were younger. And I will say more about that because we have some surveys. I want to put the presentation now in the context of the 2 days. I've sat through most of it. It's been an awful lot of material. And when you come at the end of a conference, as I'm doing, there are two sides to it. On the one hand, most of the things you wanted to say have already been said by somebody else, and quite possibly for me in this context of hormones and so on, it's probably been said a lot better than I would do. On the other hand, it does give me the opportunity of saying again a little bit from here and a little bit from there. And maybe I should say at this point that what I'm presenting in essence is in the IAS bulletin, and I wrote it as an article, and therefore you have the full detail of what I structured to talk about, easily accessible, and a lot of the all the references that go with this are there as well. So I'm going to pick my way through the presentation as I had originally envisaged it. And a bit like good sex, it's also to do with, to some extent, spontaneity. I feel I need to have a dialogue as there is in the dance, a dialogue with you, because I'm not really too good at talking for 40 minutes without getting some sort of response from the audience I'm talking with. About the context. I think it's right that I should say, and Phil mentioned it, I'm a psychotherapist, and I think that affects how I am with my patients. I would like to think I do rather more listening that way. Although I have a lot of information, I see that as important. I wanted to say optimal health. The Summit, another clinic, was referred to as Optimal Health, the Optimal Health program today. It's now quite popular. I meant to convey in the choice of that title for a clinic a very general approach to health. Now, this is an anti-aging conference, and it seems to me that a theme that's run through a lot of the presentations has been very general. When some people say to me, what do? I don't say I run an anti-aging clinic. In London, that 5 years ago, that would have been really quite provocative to say. It is now, I think, much more acceptable, Heather, isn't it? We can say that. All the things that Jennifer Krupp talked about yesterday, and I think most of you were here for that, would apply in the clinic as I see it. I say to people, it's preventive medicine I'm doing. They understand that. They understand the idea of healthy aging. Anti-aging, as a clinic, has implied in England sometimes something that is opposed to the process of aging, as opposed to do with maintaining function for as long as possible. The majority of people, and I haven't heard anyone say this at the conference this time, or not exactly perhaps like this, they want to maintain independence and then die shortly, quickly. They want to contract the period of morbidity. And I think that's a very useful concept. It fits with government policy, I might say. I wanted to say something else before I go to the meat of my presentation, and it's to do with sex therapy and dealing with sexuality as regards the symptoms of the people who come to us. The Marriage Guidance Council in England in the mid-1970s decided that they were going to take an interest in sexuality, and they set up a specialist group who would be referred the problems that came in through the door by all the other marriage guidance counselors. They developed skills, and for something like 15 years, they remained the the specialist referral unit within the larger organization. And then gradually, they were assimilated into the larger body of the organization again. I think perhaps you get my drift. When we're talking about sexuality, I believe the process is where we are not comfortable, that we put it out there, and then we send people off to do it, you see. So if we're anti-aging doctors, I think the process should be one in which we bring back into our own care the concerns and interests that are told to us about sexual function. And at this point, I want to check something out with you. How many of you are actually actively practicing as anti-aging doctors? And how many of you are aspiring to practice that way? So that sounds, it looks from where I am, that's almost like 50-50. I think sometimes I'm going to address this as though I were a sex therapist, because I can bring in things from a particular area of my training. And sometimes, of course, I'm going to speak as a doctor. I suggest that that may be the same in a way as what you're going to be doing or are doing at the moment. What I have realized is that the participants, and there's not quite as many here now as there were earlier on, come from 26 or more countries. And I think that is really so interesting that we should be such a varied group. And we come from very different specialties as well. The richness of what we're doing, I think, lies in the ability to take one's special training and apply it in a different field. That's where the creativity lies, I believe. And for that reason, when I talk to people from here, a neurologist I've spoken with, and a lot of other disciplines, I'm really interested to know what they're going to be able to contribute to anti-aging medicine from the perspective of their own training. And we will be the richer for it. I only know in England of, at this point, something like maybe 7 doctors who are specializing in anti-aging medicine and would call themselves an anti-aging doctor. We need support from one another. And this sort of meeting provides not only networking, support, the opportunity to talk about further training, supervision groups, and so on. And as one speaker said yesterday, we have to look to build our data. It was Dr. Hertog again. We have to build our data banks. We have to look at the material which will support our actions, including those things that do not support our actions, in order to give a balanced and credible view which we can present to other people. Okay, let's move on. The demographics of aging, I'm going to deal with each of these in turn, more weighted towards the bottom end. We are going to have more detailed description about the demographics, but I wanted to say that we are an aging population. There are more people in the bracket over 65. They're expanding more rapidly than any of the other population groups, any of the other decades. One other fact, because I advise a dating agency, and I was informed by this organization that 40 is a particularly significant reference point from their point of view. Over the age of 40, there are more women than men. Under the age of 40, there are more men than women. There are a lot more men born, there are rather more men born than women, and men die off all down the years a bit more quickly than women do. The practical consequence of this for a dating agency is, as you may guess, that there are a lot more women in the elder age groups than there are men, and men have more choice about their partners than women do. I won't ask you which of you have any more information about this, but it's been an interesting eye-opener to me, really, of some aspects of, for those people who come back into the marketplace of relationships later in life. And they do much more so now than they did. And if I move to the next slide, in fact, a series of slides, and I think about the attitudes. One of the things I wanted to say was that there is a changing attitude and there are greater expectations of sexuality now than there were, say, 50 years ago. I've taken a 50-year period with a somewhat token representation of the surveys that have been done. One cannot have a list of surveys without reference to Kinsey. I think people still refer to him when they're doing surveys. There may be snags about the way he went about it. He certainly didn't have an awful lot of people in the old group. So statistically it was not particularly helpful. But what he did show was the great variety of the ways that people conduct themselves sexually. And as has become clearer in some of the other surveys as well, it's not just the people do have all sorts of different ways of making love. It's also that there's great variety in the frequency of their making love as well. You start early, you go on late, would be one pattern. Whatever the style of sex that you've had, it tends to be the one that you hold to. Becker, who I knew, and I've just been talking to a colleague here, I remember his birthday party at 85, and I know for a fact, and I'm sure he wouldn't mind me saying, that he was still making love at that time, at the age of 85. I was asked, incidentally, how old may we be? What is the latest in life that we may be able to make love? And I didn't want to be pinned down on that, but I see no reason why we might not be able to make love in our 90s. And I would suggest that maybe the new means to arousal that there are has added somewhere between 5 and 10 years to people's active life. And I'm talking there about capacity for making love rather than enthusiasm. I'm talking about the physical ability to make love rather than wanting to make love. So Becker talked about the silent generation. What he meant by that was that people were interested in sex, but they tended not to talk about it. I think of this as being my parents' generation. The correlation of satisfaction with dysfunction, in preparing this, I've been musing about making that distinction between function and satisfaction. Function is a behaviorist word, it's a medical word. Satisfaction is more person-centered. And you and I are, for ourselves, going to be more interested in satisfaction than function. But it's much more difficult to measure. And a lot of the investigations that are done, for instance, of tumescence, vaginal blood flow, and so on, these are measurable, quantifiable, but they don't tell you about satisfaction. And it's certainly true of women that there is not a good correlation between those two. They can experience physiological arousal in terms of vaginal blood flow and so on, and actually not feel very excited. So we must be cautious about how we interpret those two things. The importance of intimacy despite not making love, not having sexual intercourse. Practically speaking, as a doctor, in the consulting room with patients, it's really important to have this recognition on the part of people that they need to keep physical contact and stroking and holding. I'm reminded of Rennie Spitz and the work with baby monkeys that she did. They don't thrive if they don't have physical touching. And the same applies to people at all ages. Old people in old people's homes, they wither and die for lack of contact, in my opinion. I think that's you can read it. The thing about the qualities that we seek in a relationship, it's been surprisingly similar in surveys that have been done over the last 50 years. Sex does not come top of the list of people's preferences for a partner. It comes about third or second, and companionship and security are listed in a lot of surveys ahead of sexual activity. This was a survey that I was involved with the group that did this survey. I cut out a lot of the figures because I think we wanted to spend too long looking at them. But what I wanted to say that came out of this, the obvious point this survey, that in order to make love, you have to have a partner. It's very significant, of course, because one of the problems is that for a lot of women, their partners ultimately die, and that's the time when sex stops for them. But another interesting point that I make from this study was that the duration of a relationship is more important than the age of the individual. In other words, you can have a man in his 60s or a woman who has more sexual activity because they're in a new relationship than someone, say, in their 40s who's been in that relationship for maybe 20 years. In any case, there's a tendency for sexual activity to reduce with age, and there's a tendency here that you can see to have a honeymoon period. If you take the 50th percentile, and you can see that there's a drop in men and women up to the point of about 2 years, 7.5 times in a month, and then it drops after 6 years to 3. It's pretty much the same for women. And although younger people start from a higher point, they follow the same pattern. This was a survey that John Bancroft was involved with in the States, and most of these surveys, I have to say, come from the States. And I think I've made that point already. There is a generation gap. The new old will be less accepting of abstinence. Is it not strange that desire should so many years outlive performance? I don't remember actually hearing that said on the stage, but it was too good to miss when I came across it. I wanted to use it to make a point, really. Shakespeare would not have distinguished between libido, desire, and sexual self-image. Libido, I would use the term to describe the testosterone-driven, the lust which, it leads to the man being attracted by a girl across the street. Desire is more fickle. We can stop desiring our partner even though our libido is okay. And then one needs to look to the reason why. And I will come to that later. It's complex. We often have difficulty remedying it as therapists, but it does, I think, have at least to do with communication, emotional literacy. It's a term I like. Sexual self-image is something that would like to make something of, because I find in my older men that I deal with that they may have very little libido, they may not have much desire, but it's damned important to them that they're able to make love all the same. So it's part of their sense of who they are as a person that they can do, even if they don't. And I wanted to put another plug in for men while I was talking about this, because I don't hear other people say it, and I have often thought it myself, and that is of the remarkable fidelity of a number of older men in a relationship where they are companions, still have some libido, but give up on their sexuality as part of their fidelity to the relationship. I'm not saying that this isn't matched by women in one way or another, but because men are so often described in a negative way about those things, I think it's important to say that. Biological versus chronological aging. Well, just in passing in reference, really, that we need to think in terms of biological age, not chronological age. I'm going to deal with the effects now of hormones, and those other things will be included. androgens in males. Now, I do feel this has been so well covered. I'm going to just highlight the things that directly relate to sex, although the other points are very important on, as I said earlier on, the whole of our health and all that's implied has to be taken into account in good functioning sexually. But here we have it, that androgens enhance sexual function, as described. And depletion of androgens decreases libido, strength of erection, and so on. Comparably, estrogens have an important part to play, and we've heard that discussed very well. I wanted to say about pheromones, and I haven't heard anyone talk about that this 2 days. I do think they're important, and one of the elements in sexual attraction, by the very nature of them, they are subliminal, and we are therefore not aware of them. But I think they're probably another reason for the problems there are in finding a partner for the older male with a woman who is past the menopause. Because the estrogens that are depleted, unless the woman is on HRT, I think it may account for some of the difficulties that men have in remaining attracted to women. Keep reading. I'm going to move along. Let's talk some more about hormones. These are the investigations that have been described by others this last 2 days. I do have to show concern and look at the contraindications if I'm going to consider giving testosterone to men. In the last 10 years, I think I'm only aware of there being perhaps 3 men who have had prostate cancer in the course of my giving actually testosterone. I routinely follow up 6-monthly levels of PSA and other investigations. The slope of the curve is much more important than the absolute figure of the PSA, as I imagine you probably would know. One problem arises in finding prostate cancer in people to whom I've given testosterone is that it's very hard to know whether it's causative or a chance association. I was very interested in the discussion of pro-hormones today, and on the principle that one does what is most natural within the body. One deviates as little as possible from what is natural to the body. I certainly would like myself to know more about, and will find out more about the use of pro-hormones. But I have worked with testosterone as a synthetic molecule very acceptably for a long time. It has a relatively short half-life, and I don't think it distorts the natural rhythm of testosterone production. There is clearly some suppression, and on stopping treatment, the normal levels seem to revert within about 2 weeks. I have more experience using oral treatment and can adjust the dose according to the blood levels that are achieved, despite the fact that it's going through the liver and a lot is excreted. Transdermal patch, on the whole, people don't like the redness that it creates on the arm, in my experience. The intramuscular injection that has been more popular, I think, in America. On first principles, I would prefer to have the cyclic variation, retain that if possible. Some men seem to like having testosterone that way, I think because of the extra buzz they get about 3 days out. And I have found sometimes that to give an injection and then top it up a little bit towards the end of 2 weeks. Implants, on the whole, I don't favor for the same reason as the injection, although I do believe it gives a constant level, and it certainly is convenient for some people who otherwise won't remember to take their pills. I quote that paper of Corley's from 1997, which I think still holds good. The investigations have been discussed already. I wanted to quote the Oxford paper. I've heard it referred to twice, this business of this new paper that was published in JAMA very recently. What I think I wanted to add was the difficulty there is for most of us in deciding what is an acceptable risk. If I said there's a 2% chance of having a birth defect, would that be an acceptable risk if you wanted to be pregnant, if you wanted to have a baby? Probably you would say it is an acceptable risk if you wanted it enough. Same applies here. We're talking about very small increments when a woman is on HRT. Personally, I think in most cases there is not a contraindication unless there is a specific problem like a family history of or venous thrombosis. I think the attitude as a doctor is one in which the decision is made jointly. My responsibility is to give information and support the woman in the decision that she makes. That was the second paper that I was referring. It's just come out. Obviously, we can't recommend estrogens anymore in that form, which was synthetic and given only as described. We can't expect benefits in terms of cardiac function or strokes. I wanted to make another point about this, and that was if we look at male hormone replacement, it's going to be a hell of a long time before we have any certainties about benefits and risks. If we can still have this sort of disagreement going on, what is it, 40 years since, a very long time, and there's still disagreement about the effects of long-term treatment. How long is it going to be before we've got any definitive answer about the use of male replacement therapy or replacement for some of these other hormones that we are using? Just a reminder that with giving estrogens, it's obligatory to give progesterone for endometrial protection. There has been reference today of the use of testosterone in women. It seems to me a good idea. I would prefer small doses of natural testosterone. And I quote Schifrin, it's a fairly recent paper. DHEA, we've been talked to about that today. There were two papers that I particularly noted, which I believe led to the clinical interest, and I make reference to them both there. I think that DHEA, in my experience, is helping people deal with stress. You know, subjectively, they feel more able to cope with it when there are problems in their life. I'm pretty sure that at least for a proportion of women, it's been a help in terms of libido. it needs to be given when we have measurements of the levels. I don't think it should be taken on an ad hoc basis. I've had very little in the way of problems resulting from its use. The only one which seems to be particularly a sensitive point is the small risk, I think, which is dose-related of hirsutism. And we had the point made earlier today that the pre-existing patterns of hair growth may well give us an idea of those who are predisposed to have hirsutism. There was one point there. I found taking the DHEA myself that I got something like a 20% conversion to testosterone. I think our patients like to know that we're taking these medicines. I certainly am quite happy to say that to people. IGF levels seem to go up as well taking DHEA. Now, if we look at the pharmaceutical aids to sexual arousal, we have choices, and I'm going to move this along because we're running out of time. We can give Alprostadil as a pellet. We can give Viagra as a tablet. Viagra is the best of the bunch in my experience. The 80% efficacy, well, maybe it's not quite as good as that in those who've got complicated health. There are no side effects other than those relating to people taking nitrites and recent cardiac infarction. I have very few patients who will not take Viagra because of side effects. They have to lust after their partner, at least to some extent, for it to work. I'm very impressed with the way that people being anxious can stop even the best drugs working. There are other sildenafil-like pills on the way, which may act quicker and have a slightly different profile of side effects. They're not available, or not to me yet, but they will be shortly. Anecdotally, there's no doubt that women can benefit from the use of sildenafil, and I have reports here. These are for women who have arousal problems. Clinically, I'm not above giving it a go with patients who want to try and see how they may do. I wanted to put in a little bit, particularly to this audience, speaking now as a therapist with a therapist's hat on. I do think there is much benefit in being person-centered, by which I mean that I'm interested in the whole person, and I want to make decisions jointly with them. I'm not dealing so much with the illness or with simply giving them a treatment program. I almost invariably say to people that I want to create a strategy with them for their care and work long term. I make myself available as much as they will want for me to be there on the telephone or by email. And paradoxically, what I found is the more available I make myself, the less I'm bothered by people. It was in the 80s that Lo Piccolo had this behavioral model of therapy that I thought would be worth passing on to you. Particularly with elder people, I think we need to give them permission to explore, to do things or not to do things as they wish. It's in the service of adaptation, because if there's one thing that aging is, it's a process of adaptation. Information, well, for instance, it takes longer when you're older to get an erection. It takes longer to be aroused as a woman. It may be a hands-on, you have to have direct physical contact. The whole business of making love needs to be stretched out more. There are advantages. The quality may not be any less than it was when you were younger. There was one report that said often people may think it's better than when they were younger. So those sorts of things, it's a permissive attitude, it's passing information, and also specific suggestions. We're trying to get it out as implicit, you see, specific suggestions. So the specific suggestions, an example would be the way that breathing is linked to, this is for the man, to thrusting movements. The use of the Kegel exercises. Now, as we get older, I think we need to have better technique. We need to have different ways of doing things because we may have physical disabilities. If you've got arthritis or something like that, it doesn't stop you making love, it just means you can't go about the way you used to. And intensive therapy. Well, not what I would call intensive therapy, but dealing with things like communication. I mentioned emotional literacy. It's a nice term, I think. It means that sensitivity to our emotional experience, to be able to distinguish sadness from anger, from scare, from happiness. Realizing that emotions are like the colors of the rainbow. You mix these primary emotions. We men are not so good as women at recognizing our feelings. There tends to be a bit of a time lag about it. There are these well-known suggestions that men will come up with practical solutions to the difficult day that their partners have had. And the woman would like their partner to say, yes, I understand. Be emotionally empathic. And the man says, well, I'll ring the plumber, or So communication skills. This is to say, the dance between the two people may need someone to orchestrate it. Well, I thought I'd try and say it just as simply as I could. And that's what it came down to. Thank you. Thank you.